Let me just try to add you guys, but I think I'm not a co-host. Dr. John. Let me just try to add you guys, but I think I'm not a co-host.
Oh, Sonaris, okay.
Yes.
Oh, you're good.
And Allah is here too.
Good. Well, Sonaris is going to show us how to do the merengue.
Yeah. I'm here.
Dr. John, can you please
Yeah.
make me co-host?
Yeah.
Okay. Oh, Allah, please wait. Like we are trying to admit you in. Please wait. Oh, there you are. It should work now. Yeah.
Yeah, now it's working. Good afternoon, doctors.
Good afternoon.
Sonaris, we can't see your camera. We can't see you.
Wait me.
Well, how can we see you do the merengue if we can't see? We have to see your feet. We have to see your feet.
Not the next week I will prepare a show to merengue, right? The next week.
Oh, that's cool.
Or Saturday. I don't know if you want Saturday or Monday.
How is it going? I mean,
What?
here's a guy, Sonaris. Was it a last minute decision you went to Russia, or had you been planning it? Because Mila, I was watching a video. I was talking to Emmanuel, and guess who
Okay.
pops? Guess who pops in the background? There's Sonata.
Yeah.
I didn't even know he was going.
Wow, that's cool.
So how's it going? That's your first time in Russia, right, Sonatas?
Yes, it's my first time.
How's it
My
going?
first time.
How's it going?
Yeah. Everything is good right now, but it's my first time. The temperature is very hot. It's very cold.
Very cool. It's not like that in Dominican Republic.
Dominican Republic is hot.
Yeah. I know it's like Miami.
Yeah.
Miami's one of the hottest places I've been to.
Yeah. Florida is hot.
Yeah,
It's hot.
it's in Miami, it's real muggy, like real humid. So it feels like it's even hotter than it is.
Wow.
I don't think it's muggy in Dominican.
Maybe the next year I will go to United States.
Oh, good.
Maybe.
Good.
Maybe. You live in Miami?
I live in Miami Beach, which
Miami
is
Beach.
which is an island off Miami.
Okay, yeah, it's an island.
Yeah, it's an artificial island. Actually, it was built a long time ago.
Okay.
And like Dubai, they have parts that are built on used to be ocean. Like behind me here, I think it's I think I don't know if this was swamps before, and before it was like totally undeveloped.
Okay.
Totally. And then just relatively recently, about 40 years ago, 50 years ago, they developed it. They brought in all the sand and they built these high rises. They must have built it pretty soundly. But I've been to Santiago many times. I've been to Puerto Plata. I've been to
Puerto Plata.
Barrera Beach.
Barahona.
La Parte Oeste.
Punta
No,
Cana.
Ponte, sí, y más allá, Barrera, es una ciudad de playas.
Puerto Plata, Barahona,
Sí,
Sosúa,
¿cómo se llama?
Sosúa.
Samara,
Ah, Samaná.
Samaná.
Ok, good, Samaná.
Sí, yo he visto muchas partes.
De allá.
Aparte, eh, y yo quiero ver el lugar donde vive Trujillo. Trujillo,
Trujillo.
sí, hace
Sí,
en el mar.
eso está en la capital, o sea, como por el este, San Domingo Este.
Oh, pero no hay una ciudad de la mar. Él ha tenido una casa sur de Santo
Ajá,
Domingo.
la casa de Trujillo.
Sí. Cerca de Haití.
Yes, yes. Mhm. When you will go, let me know. Maybe
Oh,
we
okay.
can
Yeah.
go.
Yeah, me gusta la zona colonial.
La zona colonial.
Sí,
Okay.
bonita. Pero no sé si cambia. ¿Sigue desarrollando esta ciudad? Porque antes está reconstruyendo.
Ha cambiado un poco, ha cambiado un poco.
No tanto.
No tanto, pero ha cambiado un poco, sí. Ha cambiado un poco. Ujú.
Eh, a second, maybe we'll start.
Dr. John, can we start?
Yeah.
Okay.
In a minute. Oh, that's right. You gotta go, right? Okay. Yeah. Let me
My
introduce.
professor is here too, Dr.
Yeah.
Zhao.
Oh, good. Okay, you ready to go? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, Dr. John Bennett for Neurosurgical TV. That's the home. Today we have a webinar by Mila Mangi, a neurosurgeon she's currently in Russia from Turkey, and she's basically going to give a talk on neurosurgery basics on headaches today. Welcome, Mila.
Thank you so much, Dr. John. I'd like to welcome all of you to my presentation. I'd also like to welcome Dr. Zaur Kajayev. He is one of the doctors working at the hospital where I am currently a resident. And today my topic is going to be all about headaches. So I hope all of you can get some takeaway messages. All right. I would like to share my screen now. Can you see my screen?
Yes, I can.
All right, let me just try to.
Yeah, you're free to speak in Russian if you want, a little bit anyways. Okay?
All right.
Because I know one of your panelists doesn't speak very good
Yes.
English, correct? But that's okay.
All right. Добрый день все. Сегодня я хочу сказать об головного боль. All right. Can you see it?
Yes.
Okay. Oh, what is happening? Okay. Headaches, a clinically detailed review. So, first of all, you have to understand what is a headache exactly. All right, a headache. Headache or cephalalgia is pain in any region of the head. Headaches may occur on one or both sides of the head. They can be isolated to a certain location or radiate across the head from one point. A headache may appear as a sharp pain, a throbbing sensation, or a dull ache. Headaches can also develop gradually or suddenly and may last from less than an hour to several days. So see, once you try to understand the basic definition of a headache, you can understand that there is not a complete diagnostic definition of this word. I mean, people can have headaches different causes, there are different causes, there are different timings, and each category has a specific further definition, which we will be discussing in the upcoming slides. All right. Okay, symptoms of headaches. When patients suffer from headaches, what symptoms can we find? For example, some primary headaches can be triggered by lifestyle factors or situations. What are the triggering factors? For example, alcohol, particularly red wine, can trigger certain type of headache in people. Certain foods, such as processed meats that contain nitrates, changes in sleep or lack of sleep. Poor posture can also help aggravate a headache. Consuming nicotine, or for example, nicotine patches. Physical activity, such as exercise. Skipped meals. And coughing, sneezing, blowing your nose, laughing, or crying vigorously can also initiate a headache. Types of headaches. So this was one of the slides which I didn't really have to spend a lot of time on because there are pictures and then there are captions. I'd first like to discuss the slide on the right side, the types of headaches, 6 types. Tension headache. As you can see in the diagram, exactly where the blue margin is located, that is the place where the tension headache mostly occurs. Around the back of the head, the temples, the forehead, almost as though a tight hat is squeezed on the head. That is the specific location of a tension headache. Moving on to migraine. Many people confuse the definition of a migraine, but you have to remember a migraine typically occurs on one side of the headache, generally. Moving towards the cluster headache. Now, even if you forget, for example, in an exam, just try to think of the word cluster. What does it mean? It's like specialized on a specific location, like a cluster, typically behind or around one eye. Moving towards the post-traumatic headache. The blue margins, as you can clearly see, frequently occurs in the temples, forehead, and the neck. Medication overuse. Now, this can be dependent on any type of medication that even students sometimes overuse and abuse. For example, when they're stressed. I remember people when we had our pharmacology exam, they were so stressed that they started overdosing on, anti-anxiety medications. They started dosing on different types of painkillers, and some of them even developed this certain type of headache. Of course, the location can vary from person to person, depending on the type of medication that you use and the dose that you've taken. A sinus headache, inside the forehead, cheekbones, and nasal cavity. Moving towards the slide on the left side. Now, this has a little bit more of a detailed type of the different types of headaches. For example, okay, I've discussed the tension headache, the migraine, and the cluster, the sinus headache as well. Now, the caffeine headache, if you abuse caffeine way too much, for example, let's say like drinking 20 cups of coffee in an hour or in a day, it's bad for you. And the location in red, as you can see, that is the location generally where people have a headache due to abusing caffeine. Moving towards hormone headaches, menstrual migraine, for example, this mostly occurs in females who are experiencing symptoms of PCOS. They can also have other sorts of conditions, for example, diabetes mellitus alongside menstruation and obesity. I've also seen patients when I was working in the ER department, when I was working in my country. I had a patient who had Down syndrome and who was obese and came into the ER complaining of a hormone headache. So different conditions, but generally the location is the same, as you can see in the red designated area. Moving on towards the hemicrania continua. I will be describing this in my further slides. Moving towards hypertension headache, we all know that the normal blood pressure is 120/80, but if for any reason it's high or lower than that, you can develop a hypertension headache. Generally, if it's above 120/80. Rebound headache. Rebound headaches, now see, concentrate on the word rebound. So it's not due to a direct insult. More commonly, it's due to a patient already having a condition, and because of that condition, they're experiencing rebound symptoms. For example, a rebound headache, or for example, pain in like another location of their body. Post-traumatic headache, also discussed in the slide. Exertion headache, if you're, at the gym using extremely high heavy weights and exercising way more than your body can take, you may develop an exertion headache. Spinal headache, it can be caused due to any spinal symptoms. Thunderclap headache and the ice pick headache, very common, and you can see over here like the general location for both thunderclap headache and an ice pick headache is the same, but there are some differences which I will be describing in my further slides. All right, hemicrania continua. This was the type of headache which was labeled here. All right, so what is it? It is a chronic and persistent form of headache marked by continuous pain that varies in severity and always occurs on the same side of the face and head. So here now we have a clear definition. It occurs on the same side of the head and the face. Some individuals with hemicrania continua have bilateral pain or pain on both sides of the head. Now this is a definition. For example, it only occurs sometimes, but generally if you were to receive a question and if you were asked to tick the correct answer, it would be it always occurs on the same side of the face and head. So please do remember this if you ever go into exams. A headache is considered hemicrania continua if the person has had a one-sided daily or continuous headache of moderate intensity with occasional short, piercing head pain for more than 3 months without shifting sides or pain-free periods. The headache may also be completely responsive to treatment with NSAIDs. For example, all of you, I'm sure, must have studied NSAIDs during your pharmacology courses. If not, you will study it further. Indomethacin is a famous drug which can be used to treat general types of headaches. All right, moving towards the right side. There are two forms of hemicrania continua. Number one, you can get a chronic form. Of course, chronic, it means patients are suffering with daily headaches. Another type is remitting, in which the headaches may occur for as long as 6 months and are followed by pain-free period of weeks to months until the pain returns. Now see, this definition is, I can understand it's a little complicated, but we'd have to study the different types of, we'd have to study the different types of conditions, like why are our patients having a pain-free period and why is the pain returning? And when the pain returns, does it return in the same order or can it transform from a remitting to a chronic stage? So this can all be discussed when you have a patient with a significant history. Hemicrania continua occurs on its own and is not a symptom of another disorder. Another very fairly simple definition. It's easy to understand. All right, if you look at the image at the top, Patients suffering from hemicrania continua, what autonomic symptoms can be present? Well, lacrimation, rhinorrhea, conjunctival injection, 70% of the time. These are like the maximum sort of most common symptoms that can be found. Other like minority, it includes like eyelid edemas or miosis. All right, common types of headache. This was another slide I found because it has a little bit more of information. For example, there's another type of headache which is caused by the temporomandibular joint at the very bottom of the image, as you can see. Its location is similar to, for example, an allergy sinus, but of course it's a little different. If you look at the left side, temporomandibular joint headache. In this type of headache, pain spreads from the temporomandibular joint to the jaw, temple, neck, or the forehead. So here are like 4 characteristic places which the headache can transfer to. Medication overuse headaches are also known as rebound headaches. Now, this point is actually, I have taken it from a very famous exam question. Some people got it wrong because they didn't know that the other name of rebound headaches is also caused by medication overuse headaches. So it's like when you're studying a topic, try to make sure that you know all the different names of the different types of diseases, different types of headaches that you're studying. Because, for example, if you don't know that there is another name, for example, rebound headaches, you are 99% at risk of getting a simple question wrong in an exam. You can lose easy marks. All right, the red flag list. What red flags do we need to look at? Especially since you're in medicine, you have to understand that some diseases have red flags which you have to concentrate on. For example, what do you look for when a person has a diagnosis other than a headache disorder? You look at these findings. Let's go through them. First, rapid onset of symptoms. For example, you have to consider arterial dissection, sinus venous thrombosis, hypoglycemia, or a seizure. Of course, there are different types of tests that you can ask the patient to go through. For example, an angiography, brain MRI with and without contrast. There are also other tests, for example, lumbar puncture and the EEG. Next, the thunderclap headache. It reaches the maximum pain intensity in less than a minute. So this one is easy to identify. It's easy to understand. And when you have a patient who you suspect may have a thunderclap headache, what is the best route to take? Well, you'd order an urgent head and neck CT and a CT angiography, also called CTA. Number 3, presence of neurological symptoms and signs. If you notice that your patient has any of the following, you'd have to consider arterial dissections, strokes, giant cell arteritis, or glaucoma. And when you suspect any of these conditions, you can easily move on towards the tests that you'd have to prescribe for your patient to make sure that you can come to a conclusion of your diagnosis. For example, MR angiography, plasma ESR, and an ophthalmic evaluation if you're worried that the patient may be suffering from glaucoma. Prominent neck pain with or without fever. Now, whenever you see this, consider meningitis. Meningitis is a very common condition. And when you understand exactly how meningitis is caused, you can easily be able to ask your patient to go through a lumbar puncture and a CSF analysis. Moving towards age. Whenever you have patients who are above the age of 50, try to check their blood pressure. Try to think about different diagnoses, and once you have your diagnosis, you can easily ask your patient to go through certain tests to confirm the diagnosis. Worsening with positional changes or the Valsalva maneuver. You have to consider sinus venous thrombosis, intracranial mass, or a CSF leak. When you think about CSF leaks, the best or the method of choice, the best method to ask your patient to do a test is the brain and the spine MRI, with and without contrast, depending on the condition, and a lumbar puncture or a CT myelography. New or worsening headache in patient with history of migraine. Whenever you get a patient who has a significant history of migraine, and then they're complaining of getting a worse type or worse form of headache, try to consider the following. Are they abusing any drugs? Are they abusing any medications? Do they have hypertension? Do they have an intracranial mass anywhere? Look at their reports. Look at their previous hospital visits if they have any. Consider the pill counting or the diary and the medication taper. Also, check blood pressure. Blood pressure is a very important test. And once you understand why blood pressure causes a lot of problems, you will easily be able to understand why do patients even develop headaches in the first place. And once you understand all of these things, you can easily ask your patient to go through the simple diagnostic tests. For example, thyroid function testing or a blood chemistry, cell counting. And then, of course, you have to review all their medications if you suspect medication overuse. Types of migraines. Many people can have migraines without aura and with aura. Now, if we discuss the without aura on the left side first, headaches that come in stages, what does that mean? It means that the patients, they don't just develop a headache all at once. No, it comes in phases, it comes in stages. Patients may experience nausea, fatigue, irritability, and sensitivity to either light and sound, or both. And when a patient complains of a migraine without aura, the location is typically localized to one side of the head. As compared to patients who have migraines with aura, usually causes visual disturbances for about 30 minutes prior to initial migraine symptoms. Now, this can be easily tested when you have an ophthalmologist, when you have the ER doctor there, and when you're considering why this patient is developing a headache and in which form, what stage, what phase, all very important questions. And patients who have migraines with auras, their taste, smell, and their speech may be affected. All right, best acupressure points for headaches and migraines. As you all know, acupressure is significant when treating certain types of conditions, for example, headaches. So even as doctors, we all can suffer headaches. So, this is a good slide for you to save, in your rooms, in your locker rooms, at the university, in the hospital, whenever you're free time. And if you suspect that you may be suffering from a headache, these are typical pressure points on your forehead, between your eyes, on your feet, at the back of your head, and on your left palm. How to treat and prevent tension headaches. Patients who will have headaches, especially tension headaches, try to think about what stresses, what triggering factors does my patient have? What is my patient suffering from? Basic question, one question that will help you get to your diagnosis much faster. Massages, ice packs, rosemary oil foot baths are very common methods. Also prescribed by many famous doctors who specialize in the treatment of tension headaches. Other general methods of improving tension headaches are posture. Posture is very important, of course. As neurosurgeons, people who study neurosurgery, and as neurologists, you have to understand that any problem in your posture can result to immediate insult to your brain, immediate insult to the body, resulting in a tension headache. Preventing eye strain. Eye strain, it can be caused by any sort of reason. If you're spending too much time concentrating on just one thing, you have to give your eyes a rest. Otherwise, if you have constant eye strain, you will develop a tension headache. Other methods to treat tension headaches: peppermint as essential oils, apple cider vinegar. Many patients are also prescribed these to try to help with their condition. All right, what is the current available treatment options for cluster headaches? Now, moving on to the cluster headache, we have three different categories: the acute treatment, the transitional treatment, and the preventive treatment. Firstly, looking at the acute treatment, what do we have? The subcutaneous injection of which drug? Sumatriptan. And we have a nasal spray, zolmitriptan. I'm sure in different countries they come with different names, but generally these are the essential types of treatments given in acute conditions. Patients may also be given inhaled oxygen. Moving towards the transitional treatment. If the acute treatment for any reason doesn't work and fails to work effectively, patients may be prescribed to undergo the transitional treatment. And what happens in the transitional treatment? Patients are required to go through a slight surgery where the great occipital nerve is blocked. Patients are given betamethasone and lidocaine with adrenaline. Also, another drug is given, followed by a slow tapering off, and the drug is called prednisone, 75 to 100 milligrams for 5 days. If none of these treatments works, then we'd have to go to the preventive treatment. And in preventive treatment, we have two types of drugs: first line and the second line. First line, a very famous drug, verapamil. And alongside verapamil, you'd have to take care of the ECG of the patient. Second line, lithium. And with lithium, patients can also be given topiramate. All right, this is a slide, one of my favorites that I took when I was reading in a research written by a German doctor. And basically, he described three different types of models. The first one is the stratified care model. Second one, stepped care across migraine attacks model, and the stepped care within migraine attacks model. If you look at the first one, stratified care model, when patients are suffering from a migraine attack, there are two associations. Either patients suffer from mild disability, in which they are given simple analgesics, or patients suffer from moderate to severe disability, in which they're given triptan. If contraindicated or is not effective with available compounds, then another drug is given, a ditan or a gepant. Moving towards stepped care across migraine attacks model. Patients suffering from a migraine attack, they give them a simple analgesic, and if nothing happens and they have a migraine attack, triptan is again considered. Moving towards the stepped care within migraine attacks model. Here, a patient suffering from a migraine attack, you administer a simple analgesic. Within the same attack with no or insufficient response, again, triptan is considered. Now, looking at a child, for example, in the pediatric department, you can have children coming in with complaint of recurrent headaches. When you look at specifically a child complaining of recurrent headaches, there's a specific classification. For example, does the child have a primary headache? If the disorder is classified, then they're offered specific treatment and, of course, follow-up. If there are any red flags, or if their headache disorder is unclassified, they're considered for review and assessment. Once the review and assessment is drawn up, the investigations are listed. And once the investigations are listed, the child is referred to a child neurologist, where a diagnosis of a primary headache is written, and if there's no primary headache, then a diagnosis of a secondary headache is considered. Once you have your correct diagnosis, you can easily understand what treatment is needed, and after treatment, what follow-up is the best for that child. Because obviously children they come in different ages. You can have a child age 10 suffering from a recurrent headache. You can also have a child age 6 suffering from a recurrent headache. So because of the difference in ages, different treatments are there and different follow-up routes are also there. All right, this is a famous question from the USMLE Step Bank. I'm going to read out the question with the options. Before I announce the correct answer, let's see which one of you can get this question right. So I'm going to begin. A 25-year-old woman comes to the emergency department because of a severe headache that began 4 hours ago. She describes the pain as pulsating and localized to the area above her left eye. She denies any nausea or vomiting. She tried an over-the-counter non-steroidal anti-inflammatory medication at home, NSAID, which provided no relief. The patient receives another first-line medication for her condition, and her symptoms soon resolve. This medication works by which of the following mechanisms of action? Does anyone in the audience want to answer this question before I announce the correct answer? Anyone?
Don't be afraid. This platform is meant for interaction. And
Dr.
feel free.
Johnson, Dr. Allah, is there anyone who'd like to even take a guess? All right, no problem.
Okay.
I'm just going to go through the wrong answers, and once we understand which options are wrong, you're going to understand the correct option. All right, so first of all, why can't it be option number A? A is the inhibition of H1 receptors. Now, as we all know, this is the mechanism of action of antihistamines. They are commonly used to treat allergies and motion sickness. It can be used to treat an acute migraine attack associated with nausea and vomiting, but this patient denies these symptoms. They don't have nausea and vomiting. Moving back towards the question, she denies any nausea or vomiting. So, hence, A cannot be the correct option. Moving towards option number B, inhibition of serotonin and norepinephrine reuptake from the synaptic cleft. Now, what is the explanation behind this? This is the proposed mechanism of action of a tricyclic antidepressant, which is used to treat peripheral neuropathy, chronic pain, resistant depression, and migraine prophylaxis. However, it is not used to treat a migraine during the acute phase. Hence, this option is incorrect. Moving towards option number C, activation of somatostatin receptors. Why is this incorrect? Now look, somatostatin receptor. This is the mechanism of action, for example, an analog, which is called osteotride. It is used to treat gigantism, acromegaly, carcinoid syndrome. It is also shown to be effective at relieving acute cluster headaches, but not a migraine headache. And here in this question, we have already have our diagnosis that the patient is suffering from acute migraine attack. So hence, option number C is off the choice. Option number E, inhibition of calcium channels in vascular smooth muscles. Why is this option incorrect? Because verapamil, which is commonly used as a prophylactic treatment for cluster headaches, it is not used to treat acute migraine attacks. Hence, option number E is incorrect. Now, since we've already discussed 4 incorrect options, we all know that the correct option is going to be number D. What is the explanation behind it? The patient's presentation is pulsatile, unilateral headache is consistent with a migraine. Triptans, for example, the drug that I discussed earlier, sumatriptan, it is used as a first-line abortive therapy for migraines, for over-the-counter NSAIDs, when the over-the-counter NSAID drugs have failed. It can be administered orally, subcutaneously, intranasally, and reaches peak blood concentration in approximately 15 minutes. Triptans also have some adverse effects. For example, they can cause the serotonin syndrome. They can cause coronary artery vasospasm and mild paresthesias. However, therefore, they are contraindicated in patients with a history of ischemic, cardiac, cerebrovascular, or peripheral vascular disease, uncontrolled hypertension, and in women who are pregnant. Now, if we go back to the question, the best answer here is option number D, activation of the serotonin receptors. I hope this is somehow easy. I can't really say that's 100% difficult. No, you just have to try to understand why each option is correct or incorrect and what is the correct explanation behind them. Most questions on competitive exams are going to be in this format, and practice is one way of trying to achieve your desired goal. And that is the end of my topic. I hope all of you enjoyed it. The floor is now open to any questions.
Thank you, Mila, for putting this together and taking the time to organize it.
No problem, doctor.
And like most students, when I was a student, I would never ask a question. I was so quiet. But I urge people in the future to don't be so timid, because it's a tool. I mean, you're at home or you're in a convenient space. It's not as if you're in a classroom and you have to be nervous. That's why I like it. It's not anonymous, but it allows you to be on the screen with neurosurgery education.
Yes, that's true. Thank you so much, Dr. John.
Yeah, and I'd like to talk just a second with your professor after the webcast. Okay?
All right.
Okay.
Actually, I don't think he's here.
Oh,
He
okay.
probably left.
Well, I just wanted to assure him it's a good tool for him to use for his students. At any rate, any questions or anybody want to introduce themselves and say hi? You don't have to, but maybe it's time you guys came out of the closet. If you don't have to, I understand. Okay, Mila, thank you very much.
No problem. Thank you so much, Dr. John. Have a lovely day.
Do svidaniya.
Thank you so much, Dr. Mila.
Thank you so much.